In this video, we will be looking at the prevalence of malnutrition in Zimbabwe. Then we will also go on to describe the IMAM performance indicators and review how we have been performing as a country. So we'll now look at the statistics on prevalence of malnutrition. There are several causes of malnutrition, as have been described in other sessions, and these have various consequences that hinder achievement of optimal nutrition, health, and development. So, we see that knowing the prevalence or the measure of malnutrition in the country is essential because it helps estimate the level of need or the caseload. When we're talking about the caseload, that is the number of children or adult patients with malnutrition that should be identified or that should be reached with the IMAM program. The malnutrition caseload also in turn guides both curative and preventive interventions that need to be scaled up or strengthened in order to identify and reach malnutrition cases and to channel investment to quality IMAM programming. It also helps make informed decisions in quantification of nutrition commodities and equipment and other food and nutrition security interventions. It is as well important to note that a reduction in the prevalence of malnutrition contributes to the attainment of several sustainable development goals. The prevalence of malnutrition can be assessed through nutritional assessments such as anthropometric assessments. Anthropometric measurements of weight, height, and mid-upper arm circumference, which you know as MUAC, by the age of a child are combined to get what we call nutritional indices. These are weight for age, height for age, weight for height, for example, and these indicate the nutrition status of a child. For example, the weight for age will indicate underweight, height for age will indicate stunting, weight for height will indicate wasting. Malnutrition indicators can be expressed in standard deviation units, or Z-scores. These are a measure of deviation of an anthropometric measure from the median, or the normal value of a reference population according to the WHO growth standards. So we'll now delve more into the classification of acute malnutrition. These classification measures, when analyzed, then give us the prevalence of malnutrition. So we'll focus on wasting, kwashiorkor, and kwashiorkor, which are indicators of acute malnutrition. So, as we see in this table, the classification of acute malnutrition for children 6 to 59 months of age. If we look at wasting, for example, the clinical measure will be weight for height. So weight for height can be checked in the weight for height Z-score lookup tables. For a child to be classified as having moderate acute malnutrition, their weight for height Z-score is greater than or equal to -3 standard deviation, they're written as SD, or it will be less than or equal to -2 standard deviation. So we are generally saying it's from -2 SD to -3 SD. And for a child to be classified as having severe acute malnutrition, their weight for height Z-score would just be less than -3 standard deviation. So that is how we classify wasting, that is using the clinical measure of weight for height Z-scores. If we then go on to look at MUAC, or mid-upper arm circumference, for a child who is said to be wasted, their mid-upper arm circumference, or their MUAC, will be greater than or equal to 11.5 centimeters or less than or equal to 12.4 centimeters. That is generally from 11.5 centimeters to 12.4 centimeters. And if they have severe acute malnutrition, their MUAC will be less than 11.5 centimeters. We'll look at the other clinical measure, that is kwashiorkor. The clinical measure is bilateral or symmetrical pitting edema. If a child does not have bilateral pitting edema, then it is not seen for moderate acute malnutrition. There is no edema. But For severe acute malnutrition, edema will be present. And then there's also another clinical term, underweight, where the clinical measure is weight for age, where the weight for age Z-score will be from -2 to -3 SD, and if they have moderate acute malnutrition, and if they have severe acute malnutrition, it will be less than -3 Z-scores. So, for all children with kwashiorkor, or that have edematous malnutrition, they are considered to have severe acute malnutrition regardless of other anthropometric measurements. So if you take the MOAC of the child or any other anthropometric measurements, as long as they have edematous, as long as they have edema, then they are termed as having kwashiorkor. The edema can be further classified as 1, if it is only located in the feet or lower legs, 2, if the edema extends to the arms or the upper body, or 3, if it extends to the face as well. And it's also important to know that children should be classified based on their most severe criterion. For example, if a child has moderate acute malnutrition based on weight for height Z-score, but according to MOAC they have severe acute malnutrition, then this child should be classified as having severe acute malnutrition because we've taken the most severe criterion of the anthropometric measurements taken. For children less than 6 months of age, clinical measurements of acute malnutrition include bilateral pitting edema, weight for length that is less than -3 standard deviations, or the infant is too weak or feeble to suckle effectively, and the mother reporting breastfeeding failure and the infant is not gaining weight at home. Acute malnutrition in children, adolescents, adults, pregnant and lactating women can be measured through visible signs of wasting, bilateral pitting edema, body mass index or BMI, using the BMI for age lookup tables for children, adolescents, as well as mid-upper arm circumference, as we have described. So representative surveys that collect anthropometric data on weight, height, and MOAC are used to estimate the prevalence of acute malnutrition. So wasting is one indicator that is sensitive to sudden changes in nutrient intake. So the prevalence of wasting may shift seasonally in response to changes in the availability of food, drought, cyclones, pandemics, and or disease prevalence. The severe acute malnutrition prevalence cutoff value of public health significance is 0%. That is, the ideal acceptable situation is to just have a SAM prevalence of 0%, and an acceptable global acute malnutrition, that is a GAM prevalence. GAM is moderate acute malnutrition plus severe acute malnutrition. So the acceptable GAM prevalence is less than 5%. So we'll further look at the acute malnutrition prevalence of Zimbabwe from 2014 up to 2020. So in the year 2014, according to the mixed survey, the MAM prevalence was 3.3% and the SAM prevalence was 0.7%. In 2015, according to the Zimbabwe Demographic Health Survey, the MAM prevalence was 3.2% and SAM prevalence of 1.1%. In 2016, there was the Zimbabwe Vulnerability Assessment Committee assessments. There's the ZIMVAC Rural Livelihoods Assessment and the ZIMVAC Urban Livelihoods Assessment. So according to the Rural Livelihoods Assessment, in 2016, the MAM prevalence was 2.5% and the SAM prevalence was 1.9%. And the Urban Livelihoods Assessment, MAM prevalence was 2.8% and SAM prevalence of 2.1%. In 2017, according to the ZIMVAC Rural Livelihoods Assessment again, the MAM prevalence was 2.0%, and the SAM prevalence was 1.2%. In 2018, there was a National Nutrition Survey where the MAM prevalence was 2.5% and a SAM prevalence of 0.2%. In 2019, the Multiple Indicator Cluster Survey, or the mixed survey, had a MAM prevalence of 2.9% and a SAM prevalence of 0.3%. And 2020, the ZIMVAC Rural and urban livelihoods assessments were conducted as well, with the rural livelihoods assessment having a MAM prevalence of 2.4% and a SAM prevalence of 2.1%, and the urban livelihoods having a MAM prevalence of 2.4% and a SAM prevalence of 1.2%. So, all SAM and MAM prevalence values are based on weight for height Z scores, except for the ZIMVAC Rural Livelihoods Assessment and Urban Livelihoods Assessment of 2020 that recorded the MAM and SAM prevalence based on MOAC by age. The caseload for malnutrition in the country will be calculated as the malnutrition prevalence multiplied by the target population multiplied by an incidence factor of 2.6 for severe acute malnutrition. So, for example, if we go on to look at the mixed survey of 2019, the MAM prevalence was 2.9% and the SAM prevalence was 0.3%. For us to calculate the caseload or the number of malnutrition cases that we expect to reach in the country or that we are supposed to identify, or rather to reach and identify in the country, will be equal to 0.3% multiplied by the target population. If, for example, we're looking at children 6 to 59 months of age, we multiply 0.3% multiplied by the population of children 6 to 59 months multiplied by our incidence factor of 2.6, then we get our caseload. Malnutrition prevalence is important for assessing the coverage in terms of identifying and admitting those in need of IMAM services. IMAM admissions are reported on a monthly basis using the routine health information system. Monitoring these admissions against the caseload or the need at different levels, for example, at facility, district, provincial, and national levels, helps us to routinely assess progress in coverage rate and if there are any possible bottlenecks in our programming, probably that are hindering us from reaching all these children as we would have seen in our caseload. So we'll now proceed to discuss our IMAM performance indicators. Now, when the malnutrition patients have been identified, admitted, and managed in the IMAM program, we need to monitor the outcomes or performance of the program against our targets. This will help provide important information on the effectiveness, management, and quality of implementation of the IMAM program. So there are 4 main treatment outcomes that we expect when one is enrolled in the IMAM program. That is, they may be cured, they may default, they may die, or they may be a non-recovery. So the performance indicators we have are the cure rate, the default rate, death rate, and non-recovery rate. These performance indicators are compared with targets or standards to indicate whether the IMAM program is reaching its objectives or not. So, we will then look at how we define the IMAM performance indicators and our targets. The cure rate. For a patient in the IMAM program to be classified as being cured, this is a patient who reaches the criteria of discharge for 2 consecutive visits according to MOAC or weight for height. The criterion of discharge can also be checked in the IMAM protocols or the IMAM guidelines. So the cure rate is the number of patients successfully discharged as cured of the total number of discharges as expressed as a percentage per reporting month. So that is the number of patients who are cured divided by the total discharges, the total outcomes that we've outlined earlier, that is cured, defaulted, died, and non-recovered, multiplied by 100 to get our percentage. So our target is to attain a cure rate of greater than 75%. This is also a sphere standard. A defaulter is a patient who is absent for 2 consecutive visits or 28 days for outpatient therapeutic programs or 2 days for the stabilization care. And the defaulter rate is the number of patients who defaulted of the total number of discharges expressed as a percentage per reporting month. As well, we calculate it as the number of patients who defaulted divided by the total number of discharge outcomes multiplied by 100. So, on this defaulter rate, our target is to have less than 15% defaulter rate. Our death rate, a patient who dies. This is a patient who died from any cause while registered in the IMAM program and whose final outcome is not known. And the death rate is calculated as the number of patients who died divided by the total discharges multiplied by 100 to get our percentage. And we aim as a country to have a death rate that is less than 5%. If it is greater than 10%, then this is alarming. We'll go on to the non-recovery rate, which is the fourth one. A non-recovered patient has been in the OTP program for more than 4 months and has not responded to treatment, or has been in the stabilization care program for more than 21 days without responding. So the non-recovery rate is the number of non-recovered patients divided by the total discharges multiplied by 100 to get our percentage. And we also aim to have a non-recovery rate of less than 15%. So we see that performance indicators for managing severe acute malnutrition should combine inpatient and outpatient care outcomes without double counting those that transfer from one to another. So for example, a child may be in the stabilization care program, that is, they're admitted in a pediatric facility or health facility, and then they are discharged to go on to the outpatient therapeutic program where they are continued to be managed from home, not necessarily at the health facility. So when we are then calculating our performance indicators, we're not supposed to double count these patients who came from the SC as well as those in the outpatient therapeutic program. IMAM outcomes are also reported monthly on the routine information system from which the performance indicators are derived or calculated. It is very important to correctly classify patient treatment outcomes in order to accurately monitor performance of the program. So now we'll look at this chart where we see the trend of our IMAM discharge outcomes from 2016 up to 2020, that is in the past 5 years. So we see that our cure rate has gradually improved, but we haven't reached our target of having it at least 75% or 75% and above. But our death rates have been generally below 5%. Our defaulter rate continues as well to increase above what we would have targeted, and the non-recovery rate as well fluctuating, but has generally had a downward trend as we would expect or as we would want to have in the program. In the past 5 years, we have not managed to reach the 75% target for cure rate. And death rate has been kept below 5%, whilst defaulter rate has not performed well as well, exceeding 15%. So the met need now, that is the number of patients that we admitted, provided with appropriate acute malnutrition care and recovered, can be calculated when we know the percentage coverage and the percentage cure rate. The product of these two give the percentage of our met need. For example, a 50% coverage and 70% cure rate is equal. This means that 35% of the needs are being met. So, for example, if we know our caseload and then we calculate the number of children or the number of patients who have been reached or who have been admitted in the IMAM program, if we say maybe we have reached 50% coverage and our cure rate is at 70%, the product of these two gives us a 35%. So that means we have only met the need of 35% of our malnutrition cases. So one of the targets or plans would then be to achieve a high coverage and also have a good or an acceptable cure rate in order to effectively meet our malnutrition needs. So we need to improve both the coverage as well as the way we manage the patients for them to be cured. Data quality improvement, for example, verifications, trainings, are some areas that need to be strengthened in order to improve our performance as a country. Also, identifying the indicators of concern at various levels of care and working on them will help us improve these outcomes.